Hello, this is Ms. Catlin. We're going to go over Chapter 34, Care of the Patient with Dysrhythmias. Your text covers all this. I gave you several links to some YouTube videos that go into some parts of this to help break it down for you. So this lecture recording is just going to cover things to help you understand the rhythms a little more, to help supplement your textbook. And the first slide here just gave you a division of the autonomic nervous system just because of the medications you're going to deal with for cardiac. Just a little brief reminder, your sympathetic division, which is your adrenergic, where some of your drugs come in that affect your beta cells, because you have the beta 1, one heart, your beta 2 receptors, 2 lungs, beta 2. So you sometimes hear like your heart rate that gets rapid and you give them a beta blocker, the allols, to slow down. So it's a beta adrenergic drug. And then if they're not selective, they're non-selective, they're going to affect a beta drug, they're going to affect both the beta 1 and the beta 2, and they can cause bronchospasms. This is just a very brief overview because you've had this before. It's just a reminder. Over here on the parasympathetic side of the autonomic nervous system, that's your cholinergic side. So one of the things you'll see on your cholinergic side, you see this decreased heart rate. Well, one of the drugs, atropine, is an anticholinergic. So it blocks the cholinergic effect that slows down the heart rate and causes the heart rate to increase. I just did this to try to give you a reminder, kind of help you when you're looking at things, because on your adrenergic side, you see here it's the stimulation of the epinephrine and norepinephrine from your adrenal gland that's sitting on top of your kidney. And so if your adrenergic side stimulates the release of these, you could think of everything, your fight or flight over here, and your cholinergic side, which is doing the opposite. It's trying to think, it's feed and breed, because it's your stimulating your GI tract, and it also affects your hormones. Feed and breed, and I can't, the other, sleep and something, I can't think of it right now. Anyway, so let me move on. Okay, so your cardiac conduction system. This is giving you a picture. This is a really good explanation of your atrial contraction. Your QRS is your ventricular contraction. Obviously, it's bigger, stronger, because the ventricle is much thicker, muscle, bigger contraction. Your T wave is when your ventricle is relaxing and filling up again, repolarizing, getting ready to contract again. So you have electrical activity coming from your SA node, which is your natural pacemaker. It sends an impulse, goes through, gets your atrials to contract. So that impulse goes to your AV node, atrial ventricular node, which is just above the junction here. It goes through here, and then it sends the impulse, and you see the arrows which way it goes, and then it comes down and does these Purkinje fibers. And you see here your bundle. So some of the things as we go along that you will see, think of this picture, come back to this picture. You will have the PowerPoints to look at. You have your textbook. You have the other videos that I gave you links to, whatever source you want to use. So when you see delays, you're going to have your PR that you're looking for your SA node, showing this coming through, going through your AV node, impulse coming through here and showing you electricity causing the contraction coming through here. As we go along, when I talk about a sick sinus, the sinus node is sick. It's not functioning quite regularly. It should have a pacemaker. It should set the pace to your heart, and sometimes it's fast, it's slow, it's fast, it's slow. It looks like it's all coming from the same place, but it's sick. You'll see supraventricular rhythm. So it's coming from somewhere above the ventricle, but not necessarily from the SA node. You'll see ventricular rhythms. So it's coming from down here, somewhere down in the ventricle is sending an impulse, whether it's an irritable thing or it's what we used to call friendly PVCs, when it was firing to get some blood, even if it's not everything. A junctional rhythm is coming somewhere in this junction in here. And then you'll see bundle branch blocks, right bundle, left bundle. You see here you have your left bundle branch, your AV bundle. So as we're talking, you will think of what those things are and coming through these fibers that can be damaged in here. So just to give you a rundown before we get into the irregular rhythms and look at strips. This is just some dysrhythmias, and as I was mentioning, sinus arrhythmia, it's an irregular rhythm coming from the sinus. Atrial arrhythmia is an irregular rhythm that's not coming from the sinus, but it's somewhere in the atrial area. Supraventricular, that can be falling somewhere above the ventricle, even in the junction. A ventricular rhythm, it's firing from the ventricle itself. A Brady is a heart rate rhythm that is less than 60. A normal rhythm is 60 to 100. Brady is less than 60. Tachy is any rhythm that is greater than 100. Bigeminy is when something is happening every other beat, which will make more sense as we go along a little here. Okay, these are all sinus. They're coming from above the sinus. It's a normal sinus rhythm, a sinus Brady, and a sinus tach. Through this little picture in here, to get you an idea of the diastole and systole, you need to understand this as the heart is being impacted with the impulses going through in the atrium and ventricular contractions, because it's how the patient's going to present, what symptoms they're going to have, and how you're going to treat them by understanding what's happening in the heart. And then more so systole and diastole for chapter 35 when we talk about heart failure, because there's systolic and diastolic failures. So anyway, this is just showing you with diastole is when the heart is relaxed and filling up. Systole is when the heart is contracting. So you have your atrium contraction followed by your ventricular contraction. So here, diastole, heart is relaxed. The atrial ventricular valves, those are the valves that open from your atrium and your ventricle. So on the right side of the heart, you have that tricuspid valve in between the right atrium and right ventricle. On the left side of your heart, you have your mitral valve, which is the one that opens from your left atrium to your left ventricle. So the heart relaxes, these valves open, the blood flows from the right atrium into the right ventricle. The other valves are open, so you have your blood flowing out of the valve, the pulmonic valve on the right side of the heart going into the pulmonary vein. And then you have your aortic valve on the left side of your heart pumping into your aorta, also supplying your cardiac perfusion to the heart muscle itself. So diastole is when everything is filling. So the blood is coming into your right atrium and your left atrium, also flowing into your ventricles. So you fill up your atrium, it contracts, and so your atrium squeeze, your ventricle squeeze, atrial squeeze, ventricle squeeze. So when we look at your rhythms, the first thing you look at is you're looking for patterns, you're looking for regularity, you're looking for a P wave before every QRS. On the slide before, nope, 2 slides, atrial contraction, QRS is your ventricular contraction. So when you look on here, these marks right here, those are marks. From here to here is 3 seconds, here to here is 3 seconds. When you go to evaluate a rhythm, you want to look at a 6-second strip. So you want to go 3 seconds, 3 seconds, that's a 6-second strip. The others, you'll look at these big squares. Each big square is 0.20 seconds. Every little tiny square inside the big square is 0.04 seconds. So there's 5 of them in the big square. That's 0.04 times 5, which is 0.20 seconds. You do need to understand this. Okay, there's a couple ways to count your rate. First, you're going to look and go, okay, do I have a P before every QRS? Is my atrium contracting and my impulse going from my atrium through my QRS, my ventricular contraction, and then repolarizing in my T wave? Yes, I do. I have a P QRS, P QRS, P QRS pattern all the way through. Do my P waves all look the same? Yes, they do. So it is coming from the same place from my SA node going through my ventricle followed by a T. So I have this regular pattern that's coming from sinus somewhere. So I have some sort of sinus rhythm. The next thing I want to do is look at my rate. There's 2 ways to do it. One is find one of your QRSs that falls on that solid pink line, and you do a countdown. So from solid line to solid line to solid line. So you start here, you count 300, 150, 100, 75. So just under the 75. So the heart rate's 70 something. $300, 150, 100, 75. The second way that you can count your heart rate is within your 6-second strip from 3 seconds, 6 seconds. So 2 of these solid lines, how many QRSs do you have? I have 1, 2, 3, 4, 5, 6, 7. How many? Count your QRSs times 10. 7 times 10, our heart rate is 70. Those are 2 methods. So my heart rate is about 70. So it's between 60 and 100, which is the regular rate. It's all coming from the same place, followed by a QRS. So I have a normal sinus rhythm. Here, I have all my P waves look the same. I have a P wave before every QRS. So I have some type of sinus rhythm. So I look for my rate, and I have 300, 150, 100. Oh gosh, sorry, hard to see these. Try this again. 300, 150, 175, 60, 50. So it looks like my heart rate is slow, definitely under 60, which would be bradycardia. The other is this a 6-second strip? I think that's a mark. 3 seconds, 6 seconds. So if this is my 6-second strip, from here to here, I have 1, 2. 2 times 10 would be a heart rate of 20. And let me try these big squares again. I have 300. Oh, so hard to see them. 300, 150, 100, 75, 60, 50, 40. My heart rate, if this is a 6-second strip, I don't know. I can't quite tell because it's faded somewhere between, it's 20 and 40. It's definitely very slow. It's less than 60. It's coming from the sinus, so it's a sinus bradycardia. What am I going to do for a sinus bradycardia? Sometimes nothing. It depends if the patient is symptomatic. What kind of symptoms would they have? Think about what the heart is doing. Something has affected that sympathetic nervous system, if you remember, the adrenergic side. The heart is slowed down. Something is blocking it. It can be after a heart attack. Certain heart attacks that supply that SA node. It could be certain drugs that slow down the heart rate. You're looking, if they have no symptoms, their blood pressure is okay, their heart rate is at least above 45, you don't do anything, because some people can walk around fine and function with that. Sometimes that is their normal resting heart rate. Often athletes are that way. I know when I swam, and when I was a runner and a swimmer, my resting heart rate tended to be in the 40s, and I felt fine. If the heart rate goes below 45, or they're symptomatic, or they're symptomatic. If you think of a heart rate less than 45, there is not that much blood being pumped out. It's not enough output to supply the heart itself with enough oxygen or the rest of the body, and we need to give them medicine, something to get the heart rate increased. So what are the things you would do as a nurse? You're looking at your ABCs, airway, breathing, circulation, looking for low blood pressure, because the effects of a low cardiac output will be hypotension, cool, clammy skin. They might be having some chest discomfort or chest pain because there's not enough oxygen getting to the heart muscle. They might have some changes in their mental status because the blood is not perfusing to the brain. So what do you need to do after you do your exam and you find symptoms? You get an IV line in. You're going to airway. Make sure the airway is patent. You're going to supply them with oxygen. You're going to put them on a heart monitor. You're going to get an IV access. You're going to do your full assessment, your neuro checks, blood pressure monitoring, and if they are perfusing well, you're going to observe them if they're not symptomatic. If they're not perfusing well, you talk about giving atropine, which I talked about as an anticholinergic, because the cholinergic side or the parasympathetic side slows down the heart rate. So you want to block that so the heart rate comes up. You want to stimulate it. The other, if you think of the sympathetic side, if you stimulate the sympathetic side or adrenergics with epinephrine to stimulate that side and get the heart rate up. Another is you have to think about preparing for a transcutaneous pacer, and we'll talk about pacers a little more in a little while. So basically that's that. So we get down to this bottom one, and you can look and go, wow, that's a fast rhythm. Again, you start with going, I have a P before every QRS. Yes, I do. Do I have a regular rhythm? Yes, it's got a regular pattern. My PR is not real long, my QRS is not real wide. I'm going to go over those in just a second. When I look at my heart rate, quickly, 300, 150, more than 100. So my heart rate's more than 100, or I can do my 6-second strip. There's 3 seconds, 6 seconds. How many QRSs do I have in those 6 seconds? I have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 13 times 10 is 130. My heart rate is definitely above 100, so it's coming from the sinus. All my P waves look the same. A P wave before every QRS, so I have a sinus tachycardia. What am I looking for on any of these? I didn't cover that. Your PR interval. Your PR interval is how long it's from the beginning of your P till you get to your R. So your Q is your first downward, R is your up, S is here, and that's your T wave. PR is telling you how long it is taking that impulse to go from that SA node down to that AV node and causing the stimulus to go through your ventricle. So your PR, is there any delay? It should be 0.12 to 0.20 seconds, and yes, you do need to know this. So if you had calipers, or you just take a piece of paper and you'd put it on here and you'd mark the beginning of your P to your R, you'd mark them, come up here and measure it out, and because I don't have that, I'm kind of looking roughly. It is less than one big square, so it is less than 0.20. It's greater than 0.12 because it's greater than 3 blocks. It's not more than 5 blocks. My PR is good. Is there a delay in my impulse going through my ventricle? That's where you're looking at your QRS. Your QRS should be between 0.04, 0.12. If you remember, these little tiny squares in here are 0.04. So your QRS should be between one little tiny square and no more than 3 little squares, which is 0.12. And if you look, you can see that these are definitely, QRS is between probably about 0.04. So it is normal. And you have a sinus tachycardia. What do you need to do about it? What are they symptomatic? Look for underlying causes. Have they been exercising? Are they in pain, stressed, have a fever, emotional, scared, anxious? Do they have heart failure? Are they in shock? You need to do an assessment, get a history, check for being symptomatic, make sure their pulse is good and strong and regular. Look for, if this is going really fast, think of what is happening in your heart. Your atrium and ventricle are squeezing rapidly. They're not having a lot of fill time. The heart muscle is working a lot because it's working fast. It's using more oxygen. It's going to get tired. So as this patient gets tired, they're not filling completely in their heart, your cardiac output is going to decrease. So with a decreased cardiac output, like happens with the bradycardia, you have a drop in blood pressure or hypotension. You may have less perfusion to the brain, leading to syncope or blurred vision. They may feel chest pain because the heart is working. They may complain of palpitations or that fluttering, pounding sensation in their chest, which again can increase the anxiety if they're already anxious and increase the heart rate some more. If the heart's not pumping well, it's pumping, and the output's decreasing, the heart's not pumping well, they may develop some crackles or jugular vein distension, which is leading to heart failure, which we will talk about in chapter 35. Drugs used to slow down the heart rate, the most common ones are beta-adrenergic blockers, beta blockers, such as the alols, atenolol and metoprolol. You might use a calcium channel blocker such as verapamil or diltiazem. What you want to do is slow the heart rate down to increase or maintain cardiac output and maintain or resume a decent tissue perfusion. You're going to get a history of what caused it. Are they dehydrated? Did they take illicit drugs? Is it a lot of caffeine? Is it stimulated by nicotine? Cocaine is a big drug. Cocaine and amphetamines like in meth that can cause this tachycardia. You're having them on a monitor. You're doing your physical assessments. You're listening for extra heart sounds for signs of failure. You're putting them on oxygen. You're trying to keep them calm. You're checking for perfusion in their body, that sort of thing. Okay, so enough of that, and we're going to go to the next slide. In here, we're looking for, we'll start with the top strip. I look and I go, okay, I have a P before every Q or S. Yes. Do my P waves look the same? Yes. Do I have a regular pattern? Yes, except for that one. Regular, 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 regular. So I have some kind of sinus rhythm. My PR, if you measure, is not greater than 0.20. My QRS is not greater than 0.12. So I have a normal sinus rhythm, except with this. This is, I have a P wave, I have a QRS, I have a T. It looks like it's coming from the same place, but if you look at your cycle, 300, 150, 175, 300, 150, 175. So my heart rate's 70 something, in the range of 75, but this one comes in early. Instead of going 1, 2, 3, 4 blocks, it's 1, 2, 3. It falls early, it's premature, it's got a normal PR, normal QRS, looks like the rest of them, just early, or it's a premature atrial contraction. Do I have to do anything? No. What can cause a premature atrial contraction? Some people live with these, have these. Sometimes they feel them, sometimes they don't. If a person has no cardiac history, it's not a big deal. If they have a cardiac history, have some problems, you want to watch because there's some kind of irritability going on there. They might be throwing these after they've had a heart attack, and might be electrolyte imbalance that's causing some irritation. So you're going to look at their electrolytes. You're going to ask history. They're going to do a 12 lead, look at other things to see if there's something causing it. It can be alcohol, it could be from cigarettes, anxiety, fatigue, fever, infection. Is it a heart problem, a valve problem in their heart? Are they in respiratory failure? Is their oxygen level dropped? Do they have a pulmonary disease? Is it dig toxicity, or is it electrolyte imbalance? So here, these are what's called PVCs, or premature ventricular contraction. You look, and first of all, I have a P before a QRS, P before a QRS. We're going to skip the odd beats. P, QRS, P, QRS. All the P's look the same. My PR is less than 0.20. My QRS is not greater than 0.12. My rate, 300, 150, 175, 60. It's kind of slow. I don't have a 6-second strip for sure. 300, 150, 175. So my heart rate's a little slow. 300, 150, 175, 60. So I have a sinus bradycardia, and then I have this extra beat. This is what I often refer to as a friendly PVC, that sometimes the heart rate's so slow it throws it in there going, hey, I need some extra perfusion here. So it's going a different way than the others. It is wide and bizarre. That QRS is wider than 0.12. It's at least 0.20. So it's wide, it's bizarre, it's going the wrong way. It's not preceded by a P wave, so it's not coming from my sinus. So it's coming from somewhere in the ventricle. It's coming early in my pattern, so it's coming prematurely, coming from the ventricle. So it's a premature ventricular contraction. And I think they don't call it contraction. I think they call it a premature ventricular beat or something like that now. Do you have to do anything about it? Not necessarily. You don't want it falling too close to that T wave, and it's not close. Because if it hits on that T wave, when your ventricle is repolarizing, it can send you into a V-tach. So that's one thing you're looking for, that it's not falling anywhere near there. Some people live with these all the time. They just have them sometimes. What kind of things are you looking for? Well, something is causing the ventricle to be irritated, or it could be because your atrium rate is so slow that the heart is trying to compensate. So you could have an electrolyte imbalance. A common cause of PVCs, or premature ventricular contractions, is hypokalemia, potassium under 3.5. Sometimes it's the other, hyperkalemia, where your potassium is greater than 5. Hypomagnesemia, where your magnesium is low, less than 1.5. A metabolic acidosis, hypoxia, might be ischemia, it could be drug intoxication, again, cocaine, amphetamines. It might have to do with heart failure, cardiomyopathy, other things, but something is causing some irritation. This PVC, premature ventricular contraction, it's white and bizarre. It's starting in the ventricle and working its way to the atrium. So the atrium has not filled completely. So obviously a PVC is not going to have much, if any, cardiac output. You don't want them so frequent that it's going to cause a problem. You're not going to perfuse, and if you have several of them, they used to treat them if you had a few, or if you did like what's down here, every other beat. That's called a bigeminy, because it's wide, bizarre, no P wave before. It's very, very wide QRS. You have a PQRS, a PQRS, so you have this rhythm with these ugly things coming in, and then you have what's called a compensatory pause. Your ventricle fires, your heart goes, whoop, let me get back in, sinus kicks in, this thing kicks again, your body does a compensatory pause, but it's every other beat. So it's a bigeminy. You can have an atrial bigeminy, you can have ventricular bigeminy, it's every other beat. Trigeminy is every third beat. Anyway, back to this. If they're not symptomatic, or they leave it alone, you look for the underlying cause. If they get very symptomatic, you're having to give them something to stop them. You might give an infusion of something like an antiarrhythmic, such as procainamide, or they don't use lidocaine as often as they used to. But those are some antiarrhythmics that you might give. Amiodarone is another, but you're looking for mainly acidosis, electrolyte imbalance, hypothermia, hypoxia. Your initial thing is to try to treat the underlying cause. Next slide. Supraventricular tachycardia. It is occurring above the ventricle. It is very fast, so it's greater than 100, so it's a tachycardia. You see here you have a P or QRS, a P or QRS. All your P's precede your QRS, so it's and they all look the same, so it's coming from your sinus. It's obviously 300, 150. It's very rapid, so it's greater than 100. So it is a sinus, it's a tachycardia. In here, this is so fast you can't tell. See, you can't clearly see P, QRS, T. They all have the same deflection. QRS is not wide and bizarre. It's less than 0.12. Your PR is not longer than 0.20. But it's firing so rapidly with these QRS. You see here where it's going along, and suddenly you have this burst and it goes away. That's paroxysmal atrial tachycardia. Abrupt. It comes and it goes. And it goes in this rapid rhythm, and then it goes out. Here, if you have an SVT or supraventricular tachycardia, not paroxysmal, this is what we call PAT. You're going to look for underlying causes, what is making this come and go. But you have a person here that comes and they're staying in this SVT, this rapid rhythm somewhere above the ventricle. It's really, really fast. Why is this a problem? Because the heart is getting exhausted. It is working very, very hard. It's not having time to fill. all the things that are going on with tachycardia, sinus tachycardia discussed, but at an accelerated rate. And this is, I picked the strip on purpose to show you the adenosine. You give 6 milligrams of adenosine IV there, and your heart flatlines. And I think as a nurse, you flatline along with the patient. I know when I've given it only twice in my career, which was enough. First time was much worse than the second time, just because of my anxiety. I shoved the drug in, watched them flatline. The purpose of this is to wake it up, because your sinus node somewhere else in this atrium is firing. You need to knock it out and get your sinus node to pick back up here and get back in a regular rhythm. Sick sinus syndrome. That's a term used. I'm not even sure if your text mentions sick sinus. It probably does, but I don't remember reading it. Anyway, sick sinus syndrome, exactly that. Your little sinus node is sick. These are a few strips that will show you that you have this rapid rate, you have these pauses, you have in and out, and so it can't make up its mind. It might go from fast to slow, like here, Brady, tachy, back and forth. It can be where you have long pauses of like a sinus arrest, and then it kicks in. It's a bradycardia of less than 50. It can look like ventricular, it can look like a few things. Sometimes this sick sinus syndrome is called a sinus nodal dysfunction, because your sinus node is not functioning right. You're going back and forth, and you might go into atrial fib, other kind of rhythms, fast, slow. We're going to talk about some more of those other rhythms, but there might be some kind of block going on. Something is irritating it. So you're watching for tachycardia, atrial tachycardia, symptomatic things. You're looking for them going into further blocks that we will discuss. Watch for the patient to become symptomatic to this, because with this irregular rhythm, rapid, slow, either one, they're going to have a decrease in the cardiac output. And your signs of this decrease will be hypotension, blurred vision, syncope, just like in everything else. The pauses that you might have can be significant enough to cause it syncope. Postural could be more so. You're listening to their lungs, because if they're not pumping well, is it backing up? Are they getting crackles in their lungs? Are they going into failure? And what do you need to do? Sometimes when they're in the really rapid rhythm, you might give epinephrine. Back up. If you want to speed up the heart, you want to give them epinephrine, which is to stimulate the sympathetic or adrenergic, or you're going to give atropine, which is an anticholinergic, to fight that if they're very, very slow rhythm. A lot of times what they have to do, if they're tachyarrhythmia, they might give them an antiarrhythmic. They'll often use metoprolol, or digoxin. They may talk about a pacemaker. You have to be careful with some of the drugs to slow down the heart rate, like metoprolol or digoxin, because if the SA node is really sick, it might block it completely and cause further problems. Let's move on. Okay, so here are what we call the heart blocks. There's multiple things. The sick sinus can be some kind of underlying block. When we next talk about atrial fib and atrial flutter, those are some kind of blocks. And then we have atrial ventricular blocks, which is the 4 types listed here. All of that means when you're talking about a block, something is blocking or disrupting the electrical current, activity, impulse that is traveling through the heart. All of these here on this screen are AV blocks, atrial ventricular blocks. So somewhere between the SA node and the impulse getting to the AV node, something is blocking that pathway. So if we're looking at our SA node impulse to our AV node, we're timing it at a PR interval, which is 0.12 to 0.20. So if you're thinking an AV block, you'd understand, oh, my PR interval, the impulse getting from my atrium to my ventricle, from my SA node to my AV node is blocked, so my PR interval is going to be greater than 0.20 because I have some sort of AV block. So our first one, which is labeled your first degree AV block, you will look and go, I have a PQRS, a PQRS, a PQRS. My rhythm is regular. My QRS is not greater than 0.12. So something's coming from the sinus. My rate is 300, 150, 175, 60, 50 something. So my heart rate is less than 60, so it's slow. Then I look at my PR and go from here, from the beginning of my P to my R wave is greater than a whole block here. So it is greater than 0.20, but it's regular, it's consistent, it keeps pulsing along. So I have a sinus bradycardia with a first degree AV block. Then I have two kinds of second degree. So this is my first level of a block. Then my second level of block, the second degree AV block, Winky block or Mobitz 1 or type 1. Most people usually refer to it as Winky block. Winky box is where your PR gets longer, 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 doesn't beat. Longer, longer, longer. So you'll measure out your PR. This is not the best of strips, but it's what I have to use. So here your PR is greater than 0.20. We'll say it's here 1.1, 0.28 roughly. And then you look here and it's probably 0.30. And then it gets a longer here and then it drops. And you have a PR, then it's longer and it drops. And a lot of times you might see it where it's PR of 0.22, 0.24, 0.26 drop. So it's PR Winky block or second degree AV block type 1 is your PR gets longer, longer, longer drop, longer, longer, longer drop. So this, I like to think of all of these AV blocks as a marriage. So you look at your first degree AV block and you say, boy, they're talking every week, but they're kind of delayed in their talk, even though they're talking, so they're having some marriage problems between the SA and the AV are not quite communicating like they should. Then they can go down in here into the second degree Winky block. They're talking some, but it's delayed. They talk less, they forget to talk. They're talking again. They didn't talk very much. They forget to talk. So that's a marriage that's in trouble because they're talking less, they forget to talk. Then they can be the second degree AV block or Mobitz type 2 where they have this PR 0.22. So your PR is a little long. See, but they talk, they don't talk. So second degree type 2 is where they sometimes just go long periods where not talking at all. They suddenly drop a beat. So you go along, you're 300, 150, 175, and then you forget. So that's a second degree AV block type 2. Third degree AV block is called complete heart block. There is no communication between the SA node and the AV node. That P wave did not cause that QRS. This is incredibly long. They're not talking to each other. They are totally disassociated. They are divorced. They are completely blocked. They are dying or dead. What do you need to do for heart blocks? As a nurse, what do you think you're looking for? You're looking to see if they are perfusing. Do they have a heart rate? Are they alert? Are they symptomatic? Is their oxygen level low? Are they on a drug such as digoxin? Are they toxic? Is their level greater than 2? Quinidine is another one that can do it. Procainamide. There are drugs that can be toxic levels and cause heart blocks, and also can lead to an arrest. It can be that they vagal down, Valsalva maneuver. It can happen from vomiting, from carotid massage. It can be excessive doses of a beta adrenergic blocker or beta blocker such as metoprolol or propranolol. They can have a heart attack, cardiomyopathy, several different things. You're looking for symptoms. You're watching. They usually don't do anything in a first degree heart block other than looking for underlying. It's when you get to second degree that you're having to do something because it's progressive and you're going to go into an arrest. So you're assessing for the medications. You're stopping anything that's going to affect this rhythm. You are notifying the provider. You are preparing for possibly getting to surgery for a pacemaker, putting in an external pacer, transcutaneous, temporary pacer while they're treating the underlying cause. We're getting ready for a possible cardiac arrest in here. Yes, you have a cardiac arrest and you are calling a code. Okay, atrial fib and atrial flutter. When you look at atrial fibrillation versus atrial flutter, both are because there's some sort of block between the impulse getting from your SA node to your AV node, or in this case from somewhere in your atrium. If you look here, these are very, very irregular little bumps or little F waves. They're all over the place. They don't look the same. They're not coming from the same place. But they are followed by a QRS that is narrow. So your QRS is normal, it's going the right route. But your atrium, if you think of, instead of coming from your SA node, in your atrium itself, multiple places are firing. So you have all these places, irritable places firing. And it's your atrium is fibrillating. Blood is not being squeezed smoothly into the ventricle, so blood can pool. And anytime blood pools, it can clot. So you have a great chance of throwing a PE or pulmonary embolus because the atrium's fibrillating, and finally it gets through, so it can have blood that pools, clots, and gets through the ventricle and out into the body and into the lung as a pulmonary embolus. It can go anywhere in the body. If you think of it coming the right side of the heart fibrillating, blood comes from the right ventricle, it has a clot, it's going to go into the pulmonary vein, into the lungs, and cause a PE. Or if it's on the left side, because the left atrium is also fibrillating, and it gets released out to the body, it can go anywhere in the body. So you look here, and there is no pattern. It's very, very irregular. So atrial fib, key, these little fibrillating things, and it's an irregular pattern. Where atrial flutter, which is actually a little more severe of a block, has flutter waves instead of this fibrillation. They have flutter waves, or as this says, a sawtooth pattern. And it has a pattern. You see here 3 to 1, 4 to 1, 3 to 1. It has a pattern, 3, 4, 3, 4, 3, 4. So what you would call here is a 3 or 4 to 1 flutter or simply an atrial flutter, because you have sawtooths, you have a pattern, so it is a regularly irregular rhythm. Atrial fibrillation is an irregular rhythm. Atrial flutter is an irregular rhythm. Neither of these are good. They're going to try to get them out of it. What are causes? Atrial fibrillation, it can be caused after cardiac surgery. It can be caused with mitral valve problems, both insufficiency or stenosis. It might be caused by hyperthyroid, or if somebody has hypothyroid, their medicines, they're on it, their TSH, their levels are off, your thyroid hormone is too high, it can send them into this symptomatic hyperthyroid state. Might be coronary artery disease following a heart attack, pericarditis, which is inflammation of the cardium. It might be hypoxia, defects, fatigue, alcohol, coffee, cigarettes. Some drugs, such as digoxin, which causes some kind of blockage, can lead to this type of blockage, atrial fib. What do you need to do? They can become symptomatic because what they call is referred to as the atrial kick, even though when you think of your P wave and your QRS, although the P wave showing your atrial contraction is not very big, but it still is some contraction contributing to your cardiac output. So if you lose this because you don't have this true atrial contraction, you're losing your atrial kick and decreasing your cardiac output. When it is uncontrolled, a patient can develop angina, syncope, heart failure, all the things that develop from a decreased cardiac output. So they want to treat underlying causes. They want to try to get the rate down. If they can convert, they will convert. Some medications, drugs to decrease the rate, can be a calcium channel blocker, such as diltiazem, verapamil. They might give them digoxin or some beta blocker, such as the metoprolol. They might try to chemically convert them with quinidine or procainamide. It's called a chemical when they give drugs to try to break them out of this rhythm, or they can do a cardioversion, which is I will discuss on the next slide about cardioversion. They may do a different thing called an ablation, which I'll talk about also, to stop those impulses. Before I go to the next slide, I want to talk about this atrial flutter. If you see an atrial flutter, I said that's a more severe block than atrial fibrillation. It's often found with like second degree heart blocks or some kind of block, and a lot of people with cardiac disease will have this. Some of the causes of atrial flutter are things that cause the atrial tissue to get larger, which increases atrial pressures. Some major causes are mitral valve disease, hyperthyroidism, a pericardial disease, infection of the pericardium, and cardiac surgery, having an MI, COPD because of atrial pressures increasing, which when we'll talk about the different kinds of heart failure. So COPD is a common cause of it, and having hypoxia. Some things to keep in mind is how severe is the block. Like here, a 4-to-1 block is pretty significant versus a 2-to-1. What is the rate? In here we'll say 300, 150, 175. So the rate is not real fast here. So even though the atrium is not kicking right, it's not filling completely to send it to the ventricle, you still are getting some. The slower the rate, the more rapid the rate, the decrease in the cardiac output. The more rapid, the heart's pumping more, the heart's working more, it has an increased oxygen need, and they're going to be might develop angina, go into heart failure, pulmonary edema, hypotension, syncope. You might be feeling the pulse and thinking that it's normal until you put them on a monitor. The interesting thing in atrial fibrillation and atrial flutter is if you listen to their heart at the same time that you put your fingers on their on their radial pulse, you're going to hear things that never mind. I'm thinking of PVCs. If you have a PVC, premature ventricular contraction, you'll hear a beat, but you won't feel it perfuse. Back up. I'm sorry. Got my brain went in the wrong place there. So usually with atrial flutter, or especially a rapid where they're symptomatic, they're going to shock them out of this rhythm. Now, shocking them. Let me go to the next slide. This is cardioversion. It's to get them out of that rhythm. This is defibrillation, which is for VFib and VTach. So for atrial flutter, we're talking about on this side called a cardioversion. It is synchronized. What does that mean when it says synchronized with the QRS? It is synchronized. You set the machine on synchronized. You put the pads on them, or in this picture of the old school where we used to have to hold them, but now it's hands off. It's kind of weird because if you're used to shocking someone, you put the pads on them, you hit the button, it shocks them. With the synchronized, you have the pads on them, you set it, and you're waiting for it to shock. So you have to do all clear, you have to wait, because it doesn't shock immediately. It has to synchronize. It checks for the QRS to shock at the right moment, to shock the heart and wake up that sinus node to pick back up and work as the natural pacemaker. As I mentioned in a very early slide, you don't want your PVC falling on a T wave. So with your shock, you don't want to shock in that T wave area when the ventricle is repolarizing, because you can send them into VTach and VFib. So that's why it's synchronized. It's at a lower joules than shocking them. They start at 1 and they slowly go up as they're trying to convert them. They are going to sedate them. They're not it's like what they call a conscious sedation, because this does not feel good and it's scary because they're going to shock the heart. It is a procedure that requires a consent. They're monitored throughout the procedure. And a very important point, when they do a cardioversion, they don't do it to everyone that's in atrial fib or flutter. Flutter is harder to knock them out of. We usually do a cardioversion with an atrial fib, and atrial flutter will often need an ablation or a pacemaker to override. So anyway, on your cardioversion, if you think of the blood pooling, if we don't know, somebody comes in, they're in atrial fib, and you have no idea how long they've been in atrial fibrillation, you don't want to immediately go and cardiovert them, because think about it. If that blood is pooled and they have some clots sitting in the atrium, do you want to shock them and get those clots flying through the body and massive stroke or throwing clots everywhere? No. So sometimes what they will do is give them something like Coumadin or heparin if they're in the hospital, something to decrease those clots before they cardiovert them. And sometimes they try to chemically cardiovert them, given the drugs that I mentioned, to try to get their rhythm to change. And sometimes they'll come out of atrial fib for a while and go right back in. So what are the other things they might do? This slide talks about here, called an ablation. You see, you have all these crazy places that are escaping these beats, and they ablate them or kill them. They have to do an electrophysiology test to find out which ones, what places are firing. They go in and they ablate it or stop them. They used to have to take them into surgery. Now they do a lot of things like percutaneously go in and cath lab and do these ablations. The other is inserting a pacemaker. Now, pacemaker can go in for all kinds of blocks, 2nd degree, 3rd degree blocks, 6 sinus rhythm, and the atrial fib and the atrial flutter. And this is just showing you some pictures here of a single chamber, dual chamber, biventricular. Biventricular is simply the leads in the ventricles. So there's multiple different type of pacemakers that get put in. I don't know if you recognize this rhythm. We're going from ventricular tachycardia to ventricular fibrillation. VTach, or ventricular tachycardia, here, obviously there's no P waves. It's extremely wide, very bizarre, up and down. That is VTach. That is VFib. It's fibrillating and it's doing, the ventricle's fibrillating, atrium is totally out of the picture, nothing's perfusing. Always check your patient. Make sure that that is not, that the leads are off or they're showering, they're shaving, and you're getting the squiggly line. Always treat the patient, not the machine. Because you can reproduce these kind of rhythms by shaking things or doing things. So always treat the patient, not the machine. So here, sometimes you can be awake initially on VTach. You won't stay awake because there's nothing perfusing. But if they are, well, that's ACLS. I won't go that deep. Anyway, so you have VTach and you have VFib. What defines ventricular tachycardia, or VTach, is when you have 3 or more PVCs, premature ventricular contractions, in a row, and the rate is greater than 100. That is the definition of ventricular tachycardia. Usually you go from VTach to VFib. Sometimes it's so fast you never see it happen, you just see this. And this VFib is cardiac arrest. VTach is very, very unstable. Sometimes you have spurts where they go in it, 3, 4, 5 beats, and they come back out into sinus, but it is telling you that something's bad. You need to treat immediately or you are going to be in a complete cardiac arrest. If you look at this, think about what's happening. There is no atrial thing. There is nothing filling that ventricle to be pumping out to the body, so it's pumping nothing. You're going to have hypotension. You're not going to be able to feel a pulse because nothing is perfusing. Their cardiac output's down, and if they have not lost consciousness, they will. What causes ventricular tachycardia? It can be ischemia, where there's a decrease of oxygen to part of the tissue of the myocardium or the heart, or actual infarction where part of that tissue dies, severe coronary artery disease, blockages, valvular heart disease, heart failure, cardiomyopathy, and again, electrolyte imbalances, especially hypokalemia. Drug intoxications, the same things that are causing other kind of blockages, such as a digoxin toxicity, procainamide, quinidine, and cocaine. Cocaine is a stimulant that can cause them to go into VTach and lead to ventricular fibrillation or VFib. Pulseless VTach is treated as a complete arrest. They are not perfusing, they are in arrest. You're doing your BLS, ACLS in here. If they have a pulse, you react immediately and do what was mentioned earlier with the cardioversion. There's some other kinds of VTach, VFib, torsades and things. We're not going to go into this. This is an introduction to your cardiac rhythms. So over here, when we're talking about ventricular fibrillation, what can cause it? The same things: myocardial ischemia, infarction, an untreated ventricular tachycardia, an underlying heart disease. It can be an acid-base imbalance. It can occur due to an electrical shock, severe hypothermia, which we learned in a previous unit, that you want to warm the core on hypothermia. You don't want to warm the extremities because it's going to rush the cold into the heart. And the big risk with severe hypothermia, moderate and severe, is VTAC and VFib. And remember, you want to warm them if they're in this rhythm and they're hypothermic, because they're not dead until they're warm and dead. Okay, so hypokalemia, hyperkalemia, elevated potassium, low potassium, and even hypercalcemia, an elevated calcium level, can lead to this rhythm. You are going to be doing defibrillation as soon as possible. That's where they want the external defibrillators available in places, because of what you want to shock them as quickly as possible, hopefully within the first couple minutes of them going into this rhythm. We're not going to go into the whole code scenario in this unit. Just to mention here, there are people that may go in and out of VTAC, and those are the people that they will put in a permanent AICD, automatic internal cardiac defibrillator. People that have them, they do feel, if the thing shocks, they do feel a shock go through their body. It is done often as an outpatient procedure, sometimes done in the cath lab. Anyway, let me move on. Here I'm just showing you some other rhythms. I'm not going to go into these a lot. This is a junctional rhythm. It's coming from the junction. There's no P wave, but it's not wide and bizarre, so it's coming somewhere in the junction. Idioventricular, all kinds of junction, but I'm not going to test you on it. I wanted you to be familiar because you will hear those terms. These are just some pictures of when I mentioned earlier the bundles, the right bundle, the left bundle. This is what it looks like when they say right bundle branch block, left bundle branch block. You can see where it's doing this. You might hear referred to as rabbit ears, a bundle branch block. This is just to show you when somebody has a pacemaker, you can see what's called pacer spikes. This one person has an atrial ventricular pacer. How do I know? Because I see a pacer spike before the P wave. So that is a pacer spike stimulating the atrium to contract. And I see a pacer spike before my QRS, which tells me the pacer is stimulating the ventricle to pace. If they had just an atrial pacemaker, you would see the spike before the P wave only. If they just had a ventricular, you would see it before there, but commonly they will have an atrial ventricular pacemaker. Pacemakers can be multiple. They can be where it kicks in when the heart rate gets too low. It can be where it kicks in to slow the heart rate down, so they have a low threshold, a lot high threshold. Sometimes when their rhythm is just erratic and severe, they have a pacer that has a set rate to try to maintain and override the body. This here, you see a pacer spike that stimulated the atrial contraction, and then you see a pacer spike which should have stimulated the ventricle, but did not, so it misfired, did not carry through. Here, the person's normal beat kicked in, so the pacemaker did not have to kick in here, and it didn't have to kick in here, so this is telling me they have this on a demand. Next line, I just put these in to kind of just be cheerful. I thought this one was cute. I don't trust those newfangled battery-powered pacemakers. If you're not looking at it, you're just listening. It shows where it's a wind-up with it. That's just what the surgeon put in. The second one, as Randy accompanies you everywhere for 6 months, the drumbeat will train your heart without the need for a pacemaker. I just thought those were cute. This was kind of an intense type of information for you, so I thought I'd stick those in at the end to kind of ease it up. I hope that this helped you get through your chapter. I hope you read your chapter before this, watch those other videos, ask me questions if you don't understand. And that is the end of my review of chapter 34.